so that I don't forget. And I'm going to turn the meeting over to David, who's going to introduce Dr. Elizabeth Cleveland. And I'm going to go ahead and make her a co-host so that she can share her screen. David, I will remind everyone to mute yourself unless you have a question so that it doesn't interfere with the presentation. Thank you.
Well, thank you, Susan, and we appreciate the opportunity to talk about our experience here in Arkansas. And I will introduce Elizabeth a little bit more in just a moment. For those of you that I think most of the people that have logged on are friends that I've met before, although for a lot of it, it's been virtual. But I'm David Deere. I'm with the Arkansas None for Nine, the affiliate here in Arkansas, and am co-director of the diagnostic clinic here in the state. And we're going to talk about increasing diagnostic capacity through ND-PAE diagnostic clinic. And we operate out of the Specialty Diagnostic Resource Center. I'll tell you a little bit more about that. Notice on this slide, if you want to go to our website, you can get in touch with us through that if you don't have contact information already. But we invite you to go. I will say our website is focused very heavily on the clinic. We have the affiliate here that posts more of the general information about FASD. We have no dedicated staff to keeping up the website, so most of it is about what the clinic is, how it operates, how to get an appointment, and that sort of thing. And as we talk today, I want to mention that we have a guiding principle that has been with us throughout the development of this center. And that is not to let the perfect be the enemy of the good. Our clinic is not what we wanted to do, it's what we were able to do. And that's what we want to talk about today is for those of you that are in states that are not, don't have the diagnostic capacity that you'd like to have. You notice I didn't say in states that don't have a clinic. I know there are a lot of states without a clinic. There are a lot of states with a clinic that still have gaps in the coverage for the state, either in terms of being able to handle the volume of referrals that you have, or just geographically being able to meet the needs of your state. We're going to talk about what we did, but even more about what you can do. It may probably your experience will be a little different from ours. As you do an assessment of the resources that you have in your state or your area, your locale where you're looking at starting a clinic, you're going to have different resources, and what you can do will be defined by those to a great extent. If we had unlimited money, we could hire staff to have clinics all day, every day. But there are very few places that can do that. Most of the places even that have a diagnostic clinic probably don't meet as frequently as they would like. There may be a few exceptions to that. So, you know, one of the first things we did was looking at the resources we had available, who were the clinicians that were on board with us. That was sort of a starting point. But also you have to say, okay, how are we going to finance this? What is our business plan? Where will we meet? Where will we have the supplies that we need for this? And where will we get referrals? And that's hitting the high points. There are other things that we might talk about as well. But what we wanted to do is have a full service center That's why our name is Diagnostic Resource Center. And we also are looking at eventually doing evaluations beyond FASD and beyond ND-PAE, which we'll talk about a little more in a moment. But we knew we wanted to begin with doing diagnostics, but we also want to build, and we'll talk a little bit about some of the early building that we've done. We have more we want to do, but we want to be able to increase screening capacity in the state, to do interventions, to provide training, to engage in research, and to collaborate with other agencies and individuals. What we often hear is, why screen if we don't have a place to send people? And why diagnose if we don't have a place to send people? So what if you have a diagnosis? If there's no support for the individual, there are no interventions. And my answer to that would be, start wherever you can and begin to build the demand. The place we were in Arkansas is people said, well, you know, is it really a problem? We're not screening, so we don't really have a need for diagnostics or interventions. And I think you can start at any point wherever you have resources and then build forward or back as you're able. So how did we get started? I know a lot of you have heard me talking a lot and promoting a lot about connecting with LIN programs. I know some of you have had some success, some of you have had no success in doing that, some of you have had limited success. And sometimes it's building that relationship over time. It may not happen the month you'd like for it to, or even the year you would like for it to. And to be honest with you, I don't recall, probably for 6 or 7 years, we had a clinic that we did as part of LIND where we didn't do diagnostics, but we invited people that suspected they had a child with FASD to come to the clinic. We would do a developmental assessment and make recommendations for their support and plan of care, things that would be put in place as though they had an FASD, because we were all pretty sure they did. We just weren't able to pull the trigger and make a diagnosis at the time. So after we did that for a number of years and had several faculty who were fairly knowledgeable and interested, but 1 year we had a dynamite group of trainees. And a number of them are shown in this picture here, along with a couple of our faculty members. And it really was, Elizabeth was a trainee at that time, and she's a speech pathologist. You see Anne, who is standing in the picture here. She was a psychology trainee with us. And then on the other side of me, at the far end of this circle, is a social work trainee. And then we also had a, not pictured in this photo, we had a health administration trainee. And that group of 4 trainees came together and said, look, we can do this. We can start a clinic. And typically in LIND, it comes from the top down. The administration or maybe the faculty say, here's what we feel like we should do. We encourage the trainees to do, they all have to do a leadership project, but it's seldom anything quite as ambitious as they did with this one. But anyway, they came together and started planning. And as I mentioned, Elizabeth was one of the leaders in this. And, you know, I really didn't go back and look at the chronology of all this. I think the year after we started this, I think we had 1 year before Elizabeth gave up her 3rd year as a trainee. She was planning to be a 3-year trainee with the LIND program. And we went to her and said, would you consider not being a trainee next year and becoming the training director? we realized that she had exceptional skills that we very rarely, if ever, saw in a trainee. I was moving toward retirement, and the faculty came together and agreed that she was the person to do that rather than tapping one of the faculty to take on that role. Elizabeth was in her PhD studies at UAMS, University of Arkansas for Medical Sciences, and about the same time got a teaching position at the University of Central Arkansas. So she has continued to be that link with Lind for us. We do have trainees that cycle through, but she has really tapped her students in the program there at UCA, and they have taken on a major role in doing a lot of the assessments for our clinic. We have a couple of other faculty that, along with Elizabeth and me, are a regular part of our clinic now, and that's Tiffany Leopard-Tassin, who is a genetic counselor, and Aubrey Love, who is a nurse practitioner. And that we originally started the clinic, and they were not part of it. And that's a good illustration of how you can work with what you have. Bringing them on has really added a phenomenal dimension to the clinic. Particularly, Tiffany has a role that we could do without, but having her there have been a couple of cases that we probably would have made a diagnosis of ND-PAE, but as a genetic counselor, she said, this really is looking more like X syndrome to me. And so we were able to send them to a geneticist who we're very fortunate to have a working relationship with, Bradley Schaefer. Some of you know Dr. Schaefer. And in a couple of cases, he diagnosed something other than an FASD. So let me mention that I think I referred to the fact that we are focusing on diagnosing ND-PAE. That's neurodevelopmental disorder associated with prenatal alcohol exposure. And we do it under the diagnosis other specified neurodevelopmental disorder, which is in the body of the DSM, other than where most people turn for ND-PAE, which is in the last chapter, which is called Conditions for Further Study. And for that reason, a lot of people say, well, that's not a real diagnosis. We're studying it, and it may be in the next DSM, but it's not in DSM-5. But under the chapter for developmental disabilities, it lists as one of the conditions is other specified neurodevelopmental disorder. And the example they give is neurodevelopmental disorder associated with prenatal alcohol exposure. So the diagnostic code comes from that chapter rather than the one that's at the end for further study. Now, most of the conditions that are part of FASD are diagnosed under the International Classification of Diseases, the ICD-10. Those are medical conditions that require a medical professional to make that diagnosis, either a physician or a physician extender like a physician assistant or a nurse practitioner. And their ability to diagnose that varies somewhat from state to state. Their scope of practice is defined by the state. And in some states, they can diagnose FAS, ARND, ARDD, partial FAS, and in other states, they can't. So I know for a lot of people that are trying to start a clinic, they're stuck on finding a physician to be part of the clinic. We didn't have a physician. We have Dr. Schaefer, who's very interested, but he does not have the time, the bandwidth to do a regular clinic. So we have set up a relationship with him where we are able to make referrals to him for anyone that we think we should go further than the ND-PAE diagnosis. He has set aside a clinic every quarter. Otherwise, he has a 2-year wait, but we can refer people to them and he can see them at least in the next 3 months. So we're glad to have that relationship. But since we had no physician, that's when we realized that, hey, we can use the DSM. As a social worker, I can diagnose under that. Psychologists can. For several semesters, we've had 2 different psychologists that were part of our program. This past year, we didn't have a psychologist. The same about occupational therapy. We had someone who was a regular part of our clinic from that profession. So some of these others sort of come and go, but we do have collaborative relationships with people from all of the disciplines that are listed here. We can refer people to them, or we can consult with them if one of them has an eating component to it. We can consult with our dietitian about that. That's something we see in a lot of our kids. We do have an audiologist who does hearing screens. We had an audiologist that was part of our program early on, who is one of, I think, the 2 people in the state who actually diagnose auditory processing disorder. And we found that a very high percentage of the kids we were diagnosing did have an auditory processing disorder. So again, you find what you have that you can work with. And what I would say is, if you don't have someone already identified, find someone, get them involved, get them interested. They could be part of a program like LEND. It's great if they are. You may not have to get the entire LEND program on board with you. If you have a psychologist or a social worker, anyone that uses the DSM, if you have them, someone that you know has an interest in FASD, you might work with them to start a clinic. So one of the big things, of course, is financial support. We are, at this point, are supported entirely by LEND. Well, actually, I should say LEND and University of Central Arkansas. UCA does provide some of the staffing that colleagues of Elizabeth and students from there. And a big thing is they provide a space for us to use for the clinic. Otherwise, the other 3 faculty members that are part of the program in Arkansas all get a little bit of their time paid by LEND. I haven't pressed them on this, but I suspect all of them are giving a lot more time to LEND than to our clinic than LEND pays for them to do. But this may change in the future. We may start charging for our services. That one good thing about that is it would allow us to potentially expand. If we're charging, we may be able to pay clinicians to do assessments. And I will say that billing for services will vary state by state. We love to do a joint assessment. It's really interprofessional rather than multi-professional or multidisciplinary, where each person does their thing independently and then maybe come together to do staffing. The 4 of us most weeks meet together with the family for our clinic. But we wouldn't be able to bill for all 4 of us to work at the same time. That's one of the downsides. But we could bill separately for assessment work that we do. But that is really going to be dependent upon your state. I've mentioned our building already. We're excited. We have a brand new building as of this fall. It's a new building that UCA built. It's an integrated health sciences building that brings all the health science programs together. And one of the things we're hoping may happen in the future is that they may adopt our clinic as the central teaching focus for PT, OT, nursing, speech pathology, audiology. They're all housed together in this building. I will mention that, however, we have a new building, but we used it a couple of times this summer, I guess, and going forward, we're this fall, until our COVID numbers change in the state, we are shifting back to an all virtual clinic. We're using telehealth, which we did in 2020 during the peak. And Arkansas has replicated our peak. I think we may have had our largest number of cases today we've ever had. So for the time being, we'll be doing virtual clinics again. The last thing that I'm going to mention and then turn it over to Elizabeth is the other thing is, where do we get our referrals? And you may think, well, that's not an issue, but if you haven't had a clinic, it may be. If you have had a clinic that's operating, you may be generating more referrals than you'll be able to keep up with. But these are some of the groups that we've looked to. Our Child Protective Services in the state's one of our big one. We have had an ongoing teaching training relationship with them for over 10 years, I guess, and they refer quite a few to us. And we have, under physicians, I just want to mention, we have a psychiatrist to whom we can refer people for further assessments or for follow-up work, medications, that sort of thing. And she refers quite a few of her patients to us for an assessment, an evaluation. They come from other places. Almost every time we do a training here locally, someone will come up to us afterward and tell us, oh, you described one of my relatives. We've always wondered what was going on with them, and we get referrals that way. So I think I'm going to stop at this point and let Elizabeth drill deeper on some of the things I've talked about. And I've told you about who she is, but I just want to say that Elizabeth has been the biggest retirement gift to me that I could possibly have. She has stated that FASD is going to be her research focus throughout her career. It was for her dissertation, where she worked on working memory with children with FASD. And it is very reassuring to me, and someone who's reaching the end of my FASD work. I don't know when that's going to be, but the end is on the horizon. I can't do it forever. And she and some others, but largely Elizabeth, have already stepped in and picked up the mantle, and I'm so thrilled to have her.
Thank you, David. Those words are so kind. And the truth is that David only thinks that he's retiring. We're not going to let him go. And you mentioned funding earlier. I will say that David is voluntary in our clinic and consistently there every week. So we certainly couldn't do it without volunteers or voluntold like David. So what I wanted to do today is get into kind of the nitty gritty of how our diagnostic process works. I am a speech language pathologist by background. I work in the Department of Communication Sciences and Disorders, which, like David mentioned, is really helpful because we have a working clinic, a speech and hearing clinic here I have graduate students who do the testing for us in the clinic. I supervise them, which is great for a lot of reasons. One, that they do the work for while the others of us can really discuss diagnostic criteria and things like that. But also this teaches the next generation of clinicians. And so we're able to put these folks out, and it's really great. So David mentioned all of these things. Again, I'll just go into a little bit more detail of them. I'll talk about our specific diagnostic process in just a second. We also refer for additional testing. David mentioned Dr. Schaefer, who we refer to for genetic testing. He mentioned our psychiatrist in town, who we refer to for specifically for alcohol-related neurodevelopmental disorder diagnosis. So if the family is really pushing for a medical diagnosis, and we know that really any child is going to be better having that medical diagnosis, David already mentioned that, then we can refer to her, especially if they are existing clients of her. That works out really well. It also helps us identify kids who are not receiving services. A lot of times we get kids who are not receiving any services, and yet they are getting kicked out of school and getting suspended, and the families are having a hard time. You all know the story. And so we can identify those impaired areas and refer for services that way too. I have started providing individualized therapy, individualized intervention through the speech and hearing clinic. And my therapy focuses on cognition and executive function. In the state of Arkansas, there's not a billing code for pediatric cognition. And so I've had to be really creative about how I approach this and how I train other speech language pathologists. My time is covered through LEND, so we don't bill for these services, but this is how these kids learn and are able to expand their cognition through this intervention. And we've been really successful with the few clients that we've had. We also do language and social skills, which are under the speech language pathology umbrella. We, this past summer, started a group, a summer group for young adults with FASD. Each one of them had an existing diagnosis, and we called it the Target Program. I love making a new acronym for things. So this was also very fun, training adults through research, group education, and treatment. Each of these, well, I'll say 3 out of the 4 adults who participated in this group were diagnosed in our clinic. One had an existing diagnosis from a long time ago. And we focused on those issues that are so important to transition, like how do you make a medical appointment if you need to go see a doctor? How do you organize your pills? What do you do about money? What money management? What does that even mean? And my speech pathology students were assigned a different topic each week. And the clients then were able to participate with people their age, because they were all right around the same age. And it really became this great cohesive intervention group without looking blaringly like an intervention group. So it was really fun and also very successful. We do lots of trainings for people in Arkansas, families, schools. We've done training for there's an agency that every foster child has to get evaluated through when they go into the foster system. We've been able to train all of the clinicians in that agency, which is really great. We recently did a presentation for a Children in the Courts conference in Arkansas. So we've trained some of the lawyers who work with these kids. And then we train other licensed medical professionals as well. And one thing that we do consistently every month is a family discussion group. We do it on the first Fridays of the month during the lunch hour, and we call it guided conversations. These families don't like sitting and hearing a lecture for a long time, and that makes a lot of sense when when you have other things to do. And so we wanted to make this motivating for the families to come. So we do training for about 30 minutes. And then the last 30 minutes, we go into discussion, and it has become a really nice resource for the family. I think they like the feeling that they're not the only ones going through what they're going through. And that has been a great thing that we've started in Arkansas as well. Okay, so now let's go into the diagnostic process. Like David said, the diagnosis that we give is other specified neurodevelopmental disorder, neurodevelopmental disorder associated with prenatal alcohol exposure. And what we are using for criteria is listed in the other section of the DSM-5 under neurobehavioral disorder associated with prenatal alcohol exposure. I've listed out those criteria. I realized that a lot of you probably know these criteria, but I thought maybe some of you might not. So I listed them here, and then I'm going to go through each one and tell you how we look for that and show you how thorough we really are with this diagnosis. The first one is a history of more than minimal levels of prenatal alcohol exposure. And then they have to have the impairments in the neurocognitive area, the self-regulation area, and the adaptive functioning area. And then, of course, it has to be onset before 18 years. The family and the client have to have clinically significant distress, and it can't be better explained by any kind of conditions that would otherwise explain it better. For history of more than minimal levels of prenatal alcohol exposure, I don't know about you all who have existing diagnostic clinics. This is the hardest piece to get a lot of times. Sometimes we'll get court-ordered reports, and we ask the foster families, well, can you confirm prenatal alcohol exposure? No, we can confirm drug exposure because they were tested at birth, but we can't confirm alcohol exposure. And so sometimes we have to dig really deep to get this. And then sometimes we don't get it at all, and we're not able to make a diagnosis. We use medical reports, caregiver reports. We have several biological mothers who have self-reported to us. A lot of times it is another biological family member who reports that as well. And then, of course, we get court reports for that criteria. For the neurocognitive impairment, the DSM-5 lists these areas of impairment, and to meet this criteria, we need one of the list. The first is global intellectual impairment. We can test for IQ in our clinic, especially when we have our psychologist there, but usually we have to plan for that. And a lot of times that is already identified, that low IQ is already identified. What we do test for in every clinic is an impairment in executive function. And I use what's called the Brief 2, which is a caregiver interview questionnaire, behavioral rating inventory of executive function, the second edition. There's also a Brief P, preschool, for those younger kids. An impairment in learning and memory is usually identified through the special education system in the schools. And then an impairment in visual spatial skills is typically already identified if they have one. But we're really looking for that executive dysfunction in the clinic. For impairment in self-regulation, same thing. They list a bunch of them, and you have to have one to meet this criteria. This is usually the easiest piece to get. If getting that confirmation of alcohol exposure is the hardest, this is the easiest. It's usually blaringly obvious when they come into our clinic. A lot of them have that diagnosis of ADHD, or anxiety or depression, or a combination of all of those things. And so we're looking for any kind of mood or behavioral regulation impairment, an attention deficit, or an impairment in impulse control. And like I said, we usually see this in the first few seconds of them being in the clinic. I will point out too, we have a self-advocate who comes to a lot of our guided conversation. She participated with us in the Target program this summer, and she really meets this mood impairment. She has severe anxiety and depression and was diagnosed late in life, mostly because she was never the blaringly obvious child. She fell through the cracks and was kind of overlooked, I think, in her, what it sounds like based on her stories. And I just think it's important to point out that not every kid that comes through our clinic has severe ADHD or oppositional defiant disorder or any of those existing diagnoses. Sometimes we're working with kids who really have that mood disorder, anxiety, and depression. The third thing we test for in here is the deficit in adaptive function. And this one lists the 4 areas, but you need 2 of these in order to meet this criteria. And one of them either has to be a communication deficit or a social impairment. And this is why it's important to get your speech language pathology friends involved, because that is under our realm of practice, communication testing and pragmatic testing. The other areas are an impairment daily living and a motor impairment. My students in the clinic are doing that communication assessment. We'll do language assessments. I've listed one here that I like a lot. It's not the only one that we use. There are lots of language assessments out there to choose from. And depending on the age, I have my favorite. Every clinician has their favorite go-tos. If they have severe articulation disorder or speech protection impairment, we can test that there. For the social impairment, there's several tests, again, that we can use. I like to use the social skills improvement system. It's also a caregiver questionnaire, and it gives us a lot of detail about social skills and problem behaviors and where the commonalities are of those impairments. We use the Vineland adaptive behavior scales to test for that daily living component. I think that's a pretty common one in most areas. And then for motor impairments, usually, again, that's pre-identified when they come into the clinic. And so you can see it really is a puzzle that we're putting together. We take each criteria, we go through them every clinic, we do it the same way, we read through them, and we, on the reports for our clients, we actually list them and we underline the ones that they meet. And so it gives any kind of person reading the report a really good idea of exactly what we were looking for and exactly where they met the criteria. I just put these on here so that you could kind of see a little bit about how we recruit for some of our trainings. This is the guided conversations, that family event that we do every month. And then this Target program was the summer group that we did. And I can share these slides as well. We can email them out so you can all have it. And then this last little slide here is just our informational flyer that we have given out to None for Nine, the NOFAS affiliate in Arkansas, to share with their families as well. And again, there's our website, arcsdrc.org. So that's all we've got as far as slides go, but I did want to open it up for any questions that we might have. So I'm going to stop sharing so that we can see our faces a little better.
And Elizabeth, we have at least one question I saw, but before we do that, let me just mention that it's good if you can do assessments for all the different criteria, as Elizabeth was explaining. But I remember well, we went to the CDC for their grantee meetings, and they had a member of the panel that put together the criteria for ND-PAE. And she told us that if you can, you want to do testing and have documentation, but again, don't let the perfect be the enemy of the good. If you can only go on clinical judgment, that's permissible. So if you don't have the capacity to do all the testing that we're talking about, but you can pretty much document from school reports or whatever that these things are going on, one could make a diagnosis. I really think it's important that we do the best that we can, but not let that get in the way of doing what we can. The question that we had was, how do we define minimal exposure? And I decided not to respond to it in the chat because it's tricky, and we are a little loose with that. And the committee specified the number of drinks per day and the number of drinks per week that they consider to be minimal. And when you exceed that, then you've met that criteria. Very few people can tell you how many drinks they had on a single occasion throughout their pregnancy. Very few people can tell you with any accuracy how many drinks they had per week or per month. So basically, if we have someone saying, yes, mom drank when she was pregnant, we take that. Now, I know there are a lot of other programs that don't. I think if we required meeting documentation of the number of drinks they had either on a single occasion or in a week, we might not diagnose anyone.
Yeah. And I will say too, if there is any question that we can't confirm the alcohol exposure, then we don't make the diagnosis. I would say 99% of our cases, the confirmation is, oh, she drank a lot during pregnancy, or she's an alcoholic and didn't find out she was pregnant until 6 months, or something like that.
I will say, if we had someone say, yeah, she really was not a drinker, but you know, she had a celebration where she had a glass of wine or two, we probably wouldn't count that,
Right.
but that's usually not what we're getting. I think for the people that have that low level drinking, we just don't get confirmation.
And a lot of times with those cases, we identify those areas of impairment. So it's not a loss coming to us and not getting that diagnosis, because we're identifying these areas that can get services. And so that's really helpful for the families.
And one other thing I wanted to mention, this is not responding to a specific question, but you mentioned the young adult that has mood disorders, largely anxiety, probably some depression. Our suspicion is those are the kids that aren't getting referred to us. If they're not doing the externalizing behavior where they're disrupting the classroom and breaking rules, breaking laws, those are the ones we usually get. And the ones who aren't doing that, very likely we may not be seeing. I think that's a real challenge for us, not only in our clinic, but nationally. As we raise awareness, hopefully we'll be able to take in more of that group as well. And one of the things she said is, when I hear people talking about FASD, they're not describing me. I just don't think that's who I am. Now, she totally agrees with us with the diagnosis, but she was the one that was sitting over in the corner stressing out, and her mom was criticizing her for not doing her work and not trying hard enough and that sort of thing. But she was the one that everybody loved, never got in trouble, but was turning it all internally and was eaten up inside.
Yeah, we've had a couple of clients like that come through the clinic. The question or comment is, I wonder if there are gender-based patterns in terms of externalizing versus internalizing those mood disorders. Perhaps, yeah. I don't think that we have enough of those internalizers come through the clinic to be able to say anything related to that. I will say that we have a pretty even number of girls come in as the boys do, and the vast majority are externalizers. So
But I will say in general, not related to FASD. I haven't seen any research on this related to FASD, but boys are much more likely to be identified as conduct problems, behavior problems, aggression, all those things. We see it from girls, but it's just viewed differently and probably expressed a little differently on the part of the individual. There's so much cultural bias and expectation that's baked into that. But we do know that boys are much more likely to be identified with those externalizing disorders.
Do you notice if that's impacted by IQ? Is that the externalizing versus internalizing? That's a great question too. We have had several clients come through the clinic who have an IQ that is low enough that could identify them as intellectually disabled. And I believe every one of those folks, 100% of them have been externalizers. So I don't think we have enough data on the internalizers to be able to say anything to that. But that's a great question.
What I do want to mention about IQ is it's not the typical child that we see, but we've seen several with high IQs. It's
yes.
not, and the alcohol can affect someone's cognition, but their IQ score could be very high, but they still may have trouble performing because of issues with working memory and executive function.
Yeah, that's a great point, David. And in that last or the fourth diagnostic criteria that has to meet either a communication impairment or a social impairment, a lot of times those children don't meet the criteria for communication impairment, and instead they meet the social impairment and the adaptive function impairment. Every kid that we have diagnosed, every adult that we have diagnosed too, has some sort of pragmatic impairment in some form or fashion. I don't think that's surprising to any of us.
And if you have a question you'd like to voice, you don't have to put them in chat. You can just chime in.
David and Elizabeth, I have a question. What percentage of the kiddos and adults that you see have a sensory processing disorder?
Oh, a high percentage of them. A lot of times that is not identified until they come to us, and then we are able to refer for occupational therapy. Sometimes we'll have an OT on our team at the clinic, and especially if the parents beforehand or the caregivers tell us symptoms of sensory processing disorders, we'll try to get the OT involved. And sometimes we just refer afterward. What I have seen, and this is not a trend that we've seen all along, but sometimes each semester has like a different characteristic of kids. And for whatever reason, this summer, we saw some children who appeared to have a sensory processing disorder, and the parents only knew sensory processing as like, give them a weighted blanket and they'll calm down, where in fact that increased their sensitivity and they kind of went off the rails afterwards. And so we've seen a lot of those folks that we've had to educate how kids and adults even portray having a sensory processing disorder or having a hard time processing any kind of sensory input.
Thank you.
Yes.
And I would shudder to think that I had to come up with a way to respond to those sensory issues. That's when we make a referral to an OT. They can do an assessment and they can say, okay, here's the sensory diet this child needs. These inputs will help address some of their sensory needs. I know just enough to be dangerous, but often to recognize something is going on and we need an OT.
Yes, absolutely.
We also have a question about the average IQ as a barrier to getting services. We have to convince to look at the functioning IQ. And that is true, but and I know in Arkansas to have a diagnosis of an intellectual disability, you have to have both a tested IQ and a functioning IQ below 70. But let me ask Elizabeth, she's a master at helping people to qualify for services under things other than intellectual disability.
Yes, because the majority of kids that come through the clinic would not meet that criteria for an intellectual disability. And so that's why I think that's one of the reasons that I love our process so much, because we really do look at so many different pieces that we can really see why a child is struggling, or perhaps why a child is struggling, and refer for those services through the school system, which then helps them get identified by the school system and get involved with a 504 plan or an IEP without having to have that low IQ that most of them don't have. Same with language scores. Most of them have within the average range of language scores.
And we also had a comment about people with FASD who have a higher IQ may have more disruptive behaviors because they recognize the difference between them and their peers and get frustrated.
Yeah.
I really think the frustration is an issue pretty much throughout the IQ continuum spectrum. One of the big things that for us is a sort of down and dirty, quick and easy way to separate between FASD and autism is the kids with FASD on the whole really want to develop relationships. And a lot of them are very good at making a friend, but terrible at keeping a friend. Where the kids with autism a lot of times are not good at making friends. And for a lot of them, it's not a life or death matter. It's not such a big deal for them.
I would also say that kids who have a lower IQ are more likely to be accepted for those behaviors by the people around them because they blame it on the low IQ. Whereas people who have that average IQ think that these kids are being bad and know better. And that is not the case. So we do a lot of that kind of education too. School systems don't necessarily like to hear it though.
I don't see another question. Let me just mention one other thing real quickly. I know we're coming to the end of our hour. I want to go back to basically where we started, and that's challenging you to think about, okay, where can we find an initial resource, an initial clinician to help us do this? And there's probably someone within your state, it may be a parent of a child with an FASD. And I really encourage this, not only in the states that don't have a clinic, and I know a number of you, I've talked to several who are really wanting to start a clinic in their state. But even if you have a clinic, you may want others. If you have anyone with an interest, follow up with them. We'll be glad to talk with anyone about that. If you have a speech pathologist, a social worker, I would start with anyone, whether they diagnose through the DSM or ICD-9. They probably have some colleagues they may be able to pull in. Start with any place you can and work to build on that. And the other thing, I didn't talk with Elizabeth about this before. I assume there wouldn't be an issue with them participating in a clinic of ours.
No, in fact, we use our clinics for training lots of people. So if you want to, I left my email address in the chat. If you're interested in watching one of those clinics, we would be happy to. Of course, we'll get the consent from the caregivers first, but we would love to have you. We always have a virtual component to the clinic. Sorry, my light keeps going off. We always have a virtual component to the clinic. So it would be really easy to add someone. And I apologize that I'm in the dark now. I have this brand new building and the light sensor doesn't work.
They think she's gone home. They've reported her to her dean that she's not on the job because she hasn't moved enough this hour. And along with that, not only could you join and see what happens, if you have someone that's interested in starting a clinic, but they feel like they don't have the expertise and would like to join us for some sessions, get some on-the-job training, we would be happy to do that with them.
And there is one more question in the chat, and it says, is the target program available to young adults in other states? Is it virtual? Yes, absolutely. I would be happy to share how we developed it. Our self-advocacy discipline coordinator for our LEND program helped me develop it. And he was at every one of our clinics too, which is really great. And it is virtual, so I can share that information with you.
And I'll mention that self-advocacy coordinator is not a man with an FASD. And thinking outside of our usual suspects in our states and thinking about the disability providers, the disability programs, that may be a place to find other allies. A lot of you have self-advocacy groups in your state that might be a good ally in this. If you're not sure about that, SARTC, S-A-R-T-C, is a national coordinating group for self-advocacy. They work largely with the organization SABE, Self-Advocates Becoming Empowered, S-A-B-E, and those groups could help you find any self-advocacy groups in your state.
Thank you, David and Elizabeth. It's been so informative. The comments have been so supportive, and we've generated a lot of great ideas and some questions to follow. So we appreciate that. The session has been recorded and we'll get that out on our website. And a copy of the slides would be very, very helpful for them to have in the future. I want to thank everybody for attending today, and thank you again for your presentation. It was absolutely fabulous.
Thank you for having me.
Bye, everyone.